You're listening to This Week in Cardiology from theheart.org on Medscape.
You can now access the latest in medical news on your Amazon Alexa-enabled device. Join me, Perry Wilson, every weekday morning for Medscape Medical Minute, where I highlight the top medical stories of the day. To add Medscape Medical Minute to your flash briefing, search for Medscape Medical Minute on Amazon and click Enable. Or open the Amazon Alexa app, go to Skills, search for Medscape Medical Minute, and click Enable. Then say, Alexa, what's the news? Or, Alexa, what's my flash briefing? I hope you'll join us.
Hi, everyone. This is John Mandrola from theheart.org Medscape Cardiology, and this is This Week in Cardiology for June 18th, 2021. This week, COVID vaccine myocarditis, Christian Eriksen, therapeutic hypothermia, and a dubious meta-analysis of revascularization trials and stable coronary artery disease. Another week has brought more good news on COVID. Hospitalizations, cases are trending lower, and this is despite the relaxing of social distancing and masking. I read that the European Union will now allow U.S. tourists. Even COVID Twitter seems less anxious, which is saying a lot. But there is more news on the vaccine-induced myocarditis story. This week, Circulation has published a series of 8 patients, mostly young males, mostly second shots, who had pretty severe myocarditis. A number of these patients required ICU admissions. All of them had high levels of troponin and abnormal CMR scans, and I'll link to that paper in Circulation. Now, along with that study came an AHA press release in which they essentially say, no worries, CDC is investigating, but in the meantime, don't delay your COVID shot. In their press release, I think they make a misleading statement. They say, according to the CDC, fewer than 1,000 cases of myocarditis-like illness were reported as of May 31st, and nearly 312 million doses of COVID-19 vaccines have been administered in the U.S. Now, that is approximately 10% of the total doses of vaccine in the U.S. have been given to young adults. But what is misleading about this is the denominator. Just as it was with the clotting issues in young females with the adenovirus-based COVID vaccine, we can't use the total number of shots given. You have to use the total number of shots given in the at-risk cohort of young males. Now, the CDC was to hold a special meeting today to review the evidence of this issue, and it was postponed due to the newly declared Juneteenth holiday. Again, I'm going to take the neutral Martian view of this whole deal. It seems wise to wait for this meeting, look at the data, discuss the data, consider the extreme low levels of circulating cases in most communities, and take a conservative, not aggressive stance to vaccinating young people. This gives time to consider key questions like, for instance, should we use only one dose in young people? Or those that have had SARS-CoV-2 infection, maybe they should delay their vaccination or get only one shot. These are questions that we need time to answer. This discussion, these questions should not be construed as vaccine hesitancy. I discussed often with patients in my clinic the truly amazing efficacy of the messenger RNA vaccines for protection against severe disease. Indeed, few therapies in medicine are this effective. I had lunch with an ID colleague this week, and he told me that neither he nor his partner had seen as in one hospitalized COVID patient who was vaccinated. This incredible efficacy of the messenger RNA vaccines in vulnerable people is a core factor in my thinking towards being conservative with vaccinating young folks. Here is why. Literally every adult in the U.S. who wants a shot or 2 shots can get it. And that vaccination actually makes that person bulletproof, so the unvaccinated pose essentially no threat to a vaccinated person. As I said last week, the risk of myocarditis from vaccine remains low, but for the young and healthy, the risk of severe COVID also remains very low. There is room for discussion and collection of more data on this issue. Next topic. The worlds of cardiology and sport collided this past week when Danish footballer Christian Eriksen suffered cardiac arrest on the field. He promptly received CPR in a shock from an AED, and he regained consciousness. His team doctor said it so perfectly. Quote, "He was gone." The resuscitation of sudden death of a young person is truly a glorious thing. Now, I've reviewed many of the news reports. When a 29-year-old athlete has cardiac arrest, the differential diagnosis includes hypertrophic cardiomyopathy, idiopathic cardiomyopathy, coronary malformations, myocarditis, and some others. A BBC News report quoted the famous London sports cardiologist Sanjay Sharma, who said that he had put Eriksen through a battery of cardiac tests before 2019 when Eriksen was on another team. Sharma says he did not have structural abnormalities in his heart at least before 2019. Sharma also said his Italian team had likely done the same. Now, none of the news reports as of the taping of this podcast have identified a cause, but Thursday it was announced that he would have an ICD. A couple general thoughts. Though this was a dramatic case because so many millions of people watched, I regularly see people saved by bystander CPR and the use of AEDs. And I hope Eriksen's save advances the cause for more citizens to learn basic CPR and for more institutions to invest in life-saving AEDs. This seems to me a completely uncontroversial public health measure. Now, another general thought on screening of athletes. Well, here is a man, Eriksen, who had perhaps the most extensive screening anyone could imagine, and still he had cardiac arrest on the pitch. This doesn't mean screening is useless, but like Wilson and Younger famously wrote, screening for disease is admirable, but in practice there are snags. Now, a snag here is that the best screeners in the world could not protect Eriksen from having cardiac arrest. This, of course, is the problem of false negative. The test Eriksen had did not detect the underlying propensity to have cardiac arrest, which is not all that uncommon in this situation. The other snag of screening athletes is that the better we get at treatment, the less valuable early detection through screening becomes. Imagine a world where every sports field has an AED. All citizens are skilled in CPR. The corollary here in cardiology and oncology is that the better we become at treating a disease, the less important is early detection. A third snag with screening is overdiagnosis. Most athletes aren't seen by professors like Sanjay Sharma. They're screened by local doctors who are not accustomed to the ECG and echo patterns of elite athletes. I've seen plenty of young people exposed to unnecessary cascade testing because doctors are not used to seeing what the normal pattern of an elite athlete looks like. And my final thought here would be whether Eriksen will get a transvenous ICD or a subcutaneous ICD. Dr. Bogdan Inaki and I have argued in JACC Electrophysiology that the recent Class 1 FDA recall of the SICD lead and generator recalls, combined with the dubious results of the Praetorian trial, argue strongly against continued use of the subcutaneous ICD. I have stopped recommending subcutaneous ICDs due to these issues, and I'll link to our article in JACC-EP. I'd appreciate any feedback on it. The next topic is a huge reversal in the ICU, and it's linked to the Eriksen story. Fortunately, prompt treatment of Christian Eriksen meant that he did not need ICU care, but lots of patients with out-of-hospital cardiac arrest suffer the effects of prolonged cardiac standstill. Right now, the current practice is to cool these patients to 32 to 36 degrees, which of course is a labor-intensive and quite invasive intervention. Recall that all the cells in our body are optimized to work at 37 degrees. And I know this may shock you, but cooling as an intervention was actually established on very low quality evidence. I know, y'all are shocked about that. Pulmonologist Josh Farkas has an excellent summary on the Pulmonary Critical Care blog. It is really good, and I'll link to it in the show notes. Regular listeners of This Week in Cardiology will recognize the pattern. It all began with small, unblinded trials that reported that cooling associated with massive absolute risk reductions in mortality. These findings were then combined with the notion that circulatory arrest survivors often have fever, which could be causal in the poor outcome. Of course, fever is a surrogate and may also just be a marker of severe illness. Hypothermia then becomes codified in guidelines. Boom, there goes equipoise. But still, we were able to do the TTM1 trial. TTM1 was an earlier trial that compared 33 degrees versus enforced normothermia at 36 degrees and found really no differences in outcome. Pulmonologist Farkas said this was enough for him to go back to 36 degrees. He writes in his blog that in addition to the extra labor and cost, 33 degrees may delay waking up, prolong vent time, and cause bradycardia. But the use of cooling 33 degrees persisted largely, he writes, because of status quo bias. Status quo bias is like, we've always done it that way. In 2019, another trial of hypothermia, 33 versus 37 degrees for non-shockable rhythms, the trial was called HyperIon, found improved functional outcomes in the cooling arm. But the p-value here was 0.04 and only 584 patients were enrolled. What's more, there was no difference in mortality in the two groups at 90 days. Now, this is the background for the big trial, the targeted hypothermia versus targeted normothermia after out-of-hospital cardiac arrest trial, TTM2 trial. This was like the CAST trial did in cardiology. TTM2 tested the status quo. 1,900 adults who presented with coma after an out-of-hospital cardiac arrest were randomized to hypothermia or normothermia. The primary endpoint was the unbiased endpoint, overall death at 6 months. Secondary outcomes included functional outcomes at 6 months measured by the modified Rankin scale. In the active arm, the 33-degree arm, the aim was therapeutic hypothermia with cooling initiated early, then slow rewarming and attempts to avoid rebound fever. At 6 months, the death rate was not significantly different, 50% versus 48%, hazard ratio 1.04, and the confidence intervals went from a 9% reduction to an 8% increase in death, really no difference. Subgroups were also consistent, no difference. There was also no difference in functional outcomes at 6 months. And more patients in the cooling arm had arrhythmias, 24% versus 17%. This was a strong trial. The size and methodology made it very strong. It had many times the combined enrollment of the earlier and positive trials. And to limit bias in TTM2, decisions regarding the withdrawal of life-sustaining therapy were performed after 96 hours by blinded clinicians in a standardized fashion. Families, too, were also blinded. Now, This Week in Cardiology likes to think about specific and general messages of trials. The specific message of this trial is that hypothermia is a non-beneficial, aggressive, and potentially harmful intervention for treating patients with coma after cardiac arrest, and practice should change. Now, this doesn't mean total nihilism. Of course, we should maintain attention to maintaining normal temperatures as was done in the trial. But the larger message is far more relevant as most of us don't manage patients in the ICU. The larger messages are, first, we must always be alert to the acceptance of aggressive strategies that were based on plausibility and methodologically weak studies. The core belief of the medical conservative is that the onus is on the proponents of aggressive invasive interventions to prove efficacy. Just because something is codified in guidelines doesn't necessarily mean it is the right therapy. The second larger message is that surrogate measures in plausibility, in this case temperature and fever, can lead us astray. And finally, we must always have the courage to test our beliefs in properly done randomized controlled trials. The TTM2 trial serves as a beacon to the power of RCTs. My friend Vinay Prasad may be right in saying that the RCT has been the greatest medical advance of this last 100 years. Last topic today is revascularization in chronic coronary artery disease. At the Euro-PCR meeting last month, investigators stirred debate with a meta-analysis of studies that looked at revascularization versus medical therapy in patients with stable coronary disease. The European Heart Journal published this paper, first author Eliano Navarrese. The inimitable David Brown and William Bowden wrote the editorial, and it was a harsh rebuttal. Now, first of all, it's unusual for a scientific meeting to label a meta-analysis of anything as late-breaking. A couple words on meta-analysis from a non-statistician. My understanding of a meta-analysis is that it is a pooling of results from multiple studies that address the same question. Ideally, the aggregation of information leads to greater strength of evidence on a specific question. So for instance, let's say a number of RCTs found trends in favor of a treatment. Each one taken alone was inconclusive statistically. Either not enough patients or there were not enough events in the single trials. A meta-analysis of these trials can combine the results and perhaps show the treatment is in fact effective. But there are huge caveats. First of all, by definition, a meta-analysis is a post hoc retrospective review. I want to quote from a beautiful paper in The Lancet from Thompson and Pocock. I'll link to that in the show notes. They wrote that the overall treatment effect estimated in a meta-analysis provides a useful guide to some average treatment effect in the trials, but it is a naive oversimplification to regard it as applying directly to future patients. Now, the second caveat is you have to be very careful about what studies to include in a meta-analysis. Studies need to be sufficiently similar, lest you are comparing apples to oranges, and more on that in the discussion of the late breaker from EuroPCR. The other challenge and caveat comes in the interpretation of plots in these meta-analyses. You can't just look at the summary effect. You have to assess for heterogeneity and weighting. Too much heterogeneity will add doubt to the conclusion, and if one trial is huge and the others are small, that huge trial drives the results. Now, with that background, let's go to the specifics of the European Heart Journal meta-analysis. The authors combined 25 trials of nearly 20,000 patients spanning nearly 50 years. Yes, that's correct, nearly 50 years, as they included the early CABG trials from the 1970s and 80s. The authors made the case for doing such a meta-analysis on the grounds that they included longer-term follow-up studies, and they specifically looked at the outcome cardiac death. They pre-specified cardiac mortality as their primary endpoint and spontaneous MI as a secondary endpoint. Now note that the included trials, these trials that they put into the meta-analysis, mostly measured all-cause mortality and all types of MI as a primary endpoint. What they found is that compared with medical therapy alone, revascularization yielded a 21% reduction in cardiac death. The risk ratio was 0.79 and the p-value was significant. Spontaneous MIs were also significantly reduced. Here the risk ratio was 0.74, and again the confidence intervals revealed that the findings were significant. The authors did something called meta-regression. This is a technique that assesses the effect of a variable on the effect size. In this case, they found that cardiac death risk was lower in studies with longer duration. The authors also did sensitivity analysis in which they repeated the meta-analysis excluding groups of trials, say trials that included post-ACS patients, or trials that included patients with chronic total occlusions, or those with CABG surgery. In each case, the sensitivity analysis revealed that the cardiac death signal remained significant. And their conclusion was that, quote, in stable CAD patients, randomization to elective coronary revascularization plus medical therapy led to reduced cardiac mortality compared with medical therapy alone. Now, my comments are that I think we could put this in a textbook of problematic meta-analysis. And on here, I will lean heavily on the brilliant editorial from Brown and Bowden. The first issue is that when the authors meta-analyzed the two primary endpoints that were most often measured in the RCTs, and this was death and MI, they found no benefit from revascularization. The second issue is that by definition, a meta-analysis is an analysis of data that is already known. I mean, you know the results of the RCTs that you put into meta-analysis. It is therefore deeply problematic to simply pick and choose an endpoint. Now here the authors chose cardiac death and spontaneous MI. While choosing cardiac death may seem reasonable, the problems are A, 1/3 of the included RCTs did not report CV death, and B, in unblinded trials, cardiovascular death is always going to be more prone to bias than is overall death. And of course, the problem with meta-analyzing just on spontaneous MI is that there is no agreement on reporting of MIs currently. Many experts feel we should report all MIs, including those after procedures. But third, and perhaps the largest issue with this meta-analysis, is that medical therapy has changed since the 1980s. Brown and Bowden include a forest plot of studies from the COURAGE trial on, that's 2007 to the present time, a time when medical therapy includes disease-modifying drugs such as statins. And when they meta-analyzed just these trials, they found no advantage to revascularization, no reduction in cardiac death. Now, of course, this should be of no surprise because, as they note in their editorial, there have been numerous meta-analyses already published that find no advantage of revascularization over optimal medical therapy. Brown and Bowden conclude that the choices made in this meta-analysis are akin to putting a finger on the scale of scientific objectivity. They liken them to the statistical tricks that Thompson and Pocock warned against in their seminal Lancet paper. I agree, and this sort of stuff really saddens me. That this was presented as a late breaker at a major scientific meeting, that it was published in a major journal, got by peer reviewers, who then allowed the authors to refute numerous properly done RCTs, tempts me to be cynical. I want to say, really? Come on, you all. If you do this sort of thing every time you publish other stuff, people are going to wonder. So in sum, atherosclerosis is a systemic disease, and skillfully done revascularization of focal disease has a clear role in helping selected people who fail medical therapy. Why? Why isn't this enough? And so that's it for this week in cardiology. As always, I'm grateful that you listened. And friends, remember, take the time to give us a rating, write us a review, tell your friends. This sort of stuff helps other people find us. Until next week, this is John Mandrola from the Heart.org Medscape Cardiology.
You're listening to This Week in Cardiology from the Heart.org on Medscape.